surgical innovation. We're gonna have another presentation from Dr. Wu Pei-Han, Deputy Director from the HeFu Center at Show-Chwan Memorial Hospital. And Dr. Wu will discuss advancing neurosurgical frontiers, moving from minimally invasive and to non-invasive treatments to Show-Chwan Memorial Hospital in Taiwan. So thank you for your presentation, and let's go ahead.
Xin chào. Good afternoon, and everybody. In fact, the topic is sometimes tricky. The non-invasive surgical treatment. The non-invasive we know, and the surgical treatment we know, but the two words combined show some paradox. In fact, I'm not a neurosurgeon, I'm a neurologist. Today, I want to talk about its. Next one. Okay, I see. We want to talk about it's not about the cancer, but for the non-invasive surgical treatment for the movement disorder. We call it functional neurosurgery. How do we achieve this kind of surgery? We use the focused ultrasound. The focused ultrasound is produced by a transducer, and the focused ultrasound have contained the 1,024 transducer in one machine. The machine is not so bigger. We could see this is MRI, and the machine, what we call the focused ultrasound, is just like this. It's just like a helmet, or we call the flame. So we could use you have the MRI, and you just need to change the bed to complete this kind of surgery. The patient didn't have any general anesthesia. You only have some local anesthesia around the frame while you need to set up the frame. And then you could check the movement disorder, check his movement or her movement while the operation immediately. What's the difference between the gamma knife we just node and the focused ultrasound? Because the effect of the gamma knife needs some time to show its efficacy, but the focused ultrasound could immediately reflect the efficacy while you perform the ablation or neurosurgery, just like the traditional radiofrequency surgery for lasering. Okay. Today we want to talk just about the thermal ablation. There is another method for the another used way for the focused ultrasound is the BBB openly, but we don't talk about the BBB openly because it's not approved by FDA, still on study. Before I want to explain the focused ultrasound, we need to know there's some restriction for this kind of techniques. We call it the scar density ratio. The scar density ratio is the consistency of our scar bone. If the scar bone had inconsistency medium, we call it below the 0.3. It would not allow the focused ultrasound to penetrate the scar bone to achieve adequate thermal elevation. The adequate scar density ratio is about the 0.4 to 0.45. And we could adjust the frequency to let the focused ultrasound beam to focus on the lateral side. But usually we focus on the central side, which we usually have to approach and hard to avoid some damage to other neurons. So the thermal ablation, we always avoid the low SDR patient. Besides the low SDR patient, we also didn't choose this kind of patient, which is more calcification of the brain. Because the calcification will have cavitation and the heating phenomena to these surrounding tissues. So that will lead us to ablation the area we don't want to influence. So besides this, we just need to set the patient on the frame and using the cooling water to heat down the skin temperature of the patient. Just like this. And after the we set up the frame. We use the brain CT before the operation to compare with the intraoperative MRI to achieve the correct the accuracy and the precision of the neurosurgery. It's what we see in the operator screen. So we see the red spot here is the temperature and where we do in the brain. In nowadays, we have two indications approved by FDA for the MRgFUS focused ultrasound. The one is the essential tremor. The essential tremor across age is around 1% incidence. And here has a bimodal incidence from hereditary and degenerative. Why we had the essential tremor? Because the essential means that we don't know why. But in recent days, the 2020, we find that the Taiwan team finalized the basic pathophysiology of this kind of disease. Because of overproducing of the fiber from our cerebellum area, so we would have the tremor, especially a kinetic tremor while we move. So we just needed to do is block the pathway from our cerebellum to the cortex. And we have included 51 Taiwanese patients to treat by the MRgFUS focused ultrasound. It's the most number of the Chinese populations. So the infected case is like this. This is a typical essential tremor. We could see he couldn't even hold the pen to writing a word. And the downward is just after treatment immediately. You could achieve this in the MRI room, even in the AR room. We just leave the MRI room and let her draw this. The patient could discharge out of the hospital 1 day after the operation without any complications or wound we needed to care about. So nowadays, in the recent review, we have known that in fact the efficacy of the MRgFUS ultrasound for treating the essential tremor is nearly equally to the traditional DBS surgery. But he had no complications like the traditional surgery, like we know the ICH or we call the infection. Besides the essential tremor, the other indication is the Parkinsonism. The Parkinsonism have 4 components. This is a typical Parkinsonism picture. We have the stupid posture, slow, rigidity, and tremor. Why we have the Parkinsonism? Because of the death of a neuron from our substantial nigra compacta. So it influences our direct and indirect pathway of dopamine synthesis. But in the target of Parkinson's disease is not like the essential tremor have a very, very different target as a VIM. We have also tried so much target. So we want to talk about why there is so many choices while we try to choose the Parkinson's disease. Because besides of the basal ganglion system, it has also influenced our cerebellum system to influence our movement determination. So if you just block the basal ganglion circuit, there still have some patient had a tremor or other Parkinsonism if we don't block the cerebellum system. So as the same, if just we block the cerebellum system, we like just block the VIM, it still have some tremor because of the basal ganglion circuit problem still exist. So only the PD tremor have a dopamine response and a dopamine non-response. So if he had a dopamine non-responsive tremor, you are more likely the cerebellum system. If he have a dopamine response tremor, you are more likely the basal ganglion system. So the target for the Parkinson disease, as our experience, that would be the pidosamic tract. They may be not so familiar with this kind of structure. In fact, it's not a new target, but it emerged in recent 2 or 3 years. About this target is famous by the Takaomi Taira, Professor Taira. He do so much PD tracheotomy to treat the PD patient. And recently, when was published a PD tracheotomy paper for the result, and it was just approved by FDA for treat the Parkinson disease 2 days ago. What is the pidosamic tract? It is from the GPI, gross pallidus internals, to our thalamus, the way of the tract. You would have a convergence in the Fourier's edge. So in fact, we are not ablating the whole tract, but only focus on the Fourier's edge. In fact, there was a paper published by Swiss include 51 patients treated by the PP tracheotomy. And it showed a very good prognosis, even some kind of better than the traditional DBS surgery. And its adverse effect only have some scalpel hypothesia. And one have showed the anxiety episode. It's just that. But 7 patients have decreased the volume of the voice about 3 months. There has no ICH infection or suicide episode. So let me show the first case. This is a 76-year-old patient. He had Parkinson's disease for over 10 years, but is too old, so he don't want to receive the traditional DBS surgery. But you can see, if he is out of medication, he need to use the wheelchair to move. And he even can get up by himself. Walk slowly and very unstable. If no one could assist him, he would falling down. He would fall down. This is after surgery for 6 months. You could see we performed the PD tracheotomy over his right hemisphere. And he had improved the first faster in the head movement. And the second, he could stand up by himself, even out of the medication. He walks still slow, but looks like more stable. So you could see he still had some tremor over the right side because we have treated the right hemisphere, so for the left side. And he have a more stable posture. And the second one is a 70-year-old lady. He also have the Parkinson's disease for over 10 years. And he is a colon cancer stage 4 with multiple metastases. So he could not receive the DBS by the national insurance by our country. So he seek for the non-invasive and the low-risk treatment way. because of the time I was. He also could not stand up by himself and needed someone to assist her. And even with the assistance by the wheelchair, she still can walk. So we don't test the postural stability. This is the 1 day after the surgery. He also performed the right hemisphere pallidotractomy. And 1 day after surgery, he could stand up by herself without assistance and walk. And the posture instability also improved. So, according to our data, the good prognosis is directly related to the response before your operation to the levodopa. If you have a good response to the levodopa before the surgery, you would also have the good response to the MRgFUS ultrasound to the PTT tracheotomy. According to our data, is the comparison between the MRgFUS ultrasound and the DBS to the Parkinson's disease. We could see that there seems to have a similar effect of the impact for the Parkinson's disease, but there's a very, very low complication rate compared to the DBS surgery. But in fact, we only developed the MRgFUS ultrasound to treat the Parkinson's disease for 2 or 3 years. So if over 5 years, we still have no data. But I think that this is a very amazing breakthrough to this disease. So the summary is the MRgFUS ultrasound is a minimal invasive, or we call the non-invasive procedure. The prognosis of MRgFUS ultrasound is weighted with SDR score. If the SDR less than 0.35, we will predict the prognosis. The VIM sonography for essential tremor is safe and promising. The target of the treatment of PTT is still uncertain, but because this PTT is created before 2 weeks or 1 month ago, now the PTT tracheotomy is approved by FDA. I think that is a new way to treat the Parkinson's disease. Thanks for everyone.